My name's Barbara Bainbridge, and I'm one of the nursing education coordinators from Northwest AHEC, which is a program of Wake Forest School of Medicine and the part of the North Carolina AHEC system. And I'd like to welcome you and thank you for choosing to attend today's conference, our 2018 Geriatric Conference, Updates on Caring for Aging Patients. We just have a great crowd today and some wonderful speakers, so I think you're going to have an awesome day. For our first presentation of this morning, who's going to do an overview of aging in North Carolina, I'd like to welcome Blair Barton-Percival. Blair received his undergraduate degree from Cornell University in Ithaca, New York, and then moved west to study at the University of Michigan in Ann Arbor. At the University of Michigan, he earned his Master of Social Work degree and a certificate in gerontology. He's enjoyed living in North Carolina since the fall of 2000, and he is currently the director of the Piedmont Triad Regional Council Area Agency on Aging. Please help me welcome Blair Barton-Percival.
Thank you, Barbara, for that welcome. I appreciate it. I'm glad to be here, glad to be anywhere, to be quite honest. Happy Friday. Yeah, happy Friday. I know it's a little chilly out there, but let's give it a little bit of energy. Happy Social Work Month. Nice, nice. That's exactly right. How many social workers do we have in the room? Okay, a few. What is Social Work Month this year? Anybody know? It is social workers, leaders, advocates, champions. So that's exactly right. Do a lot of work. I am a degreed social worker. I practice administration on a daily basis, but that's certainly my roots come from social work. So is anyone in this room aging? Yeah. I'm thinking somebody said not me, check her for a pulse. We're all aging. Sometimes quickly, sometimes slowly. Guess it depends on the day. What you ask me, hopefully this presentation will be relevant to everybody. You'll note on my opening slide there it says March 3rd. It is actually March 2nd. That's how committed I was. I thought this was going to be on Saturday, and I was still willing to be here. I submitted this a while ago, and once you submit it, you cannot change it. So it is what it is. A little bit about me, of course, give me a stage and a microphone and a captive audience, and we're kind of in for trouble, but I'm glad to be here. Not long ago, I was visiting my parents in Canada, and I had driven up, stayed a few days, and was preparing to leave, and was standing at the door saying our goodbyes, and my mom reached out and stuck a few dollars in my hand and said, "Here you go, honey, here's some gas money." And my dad promptly looks at her and says, "Sheila, we're saving for our old age." And my mom, without missing a beat, looks back at him and says, "Harvey, we're there." So this is personal. My folks are in their 70s, mid-late 70s. And as you'll find out, I think hopefully I will make it there someday. So this is certainly self-interest and trying to get things ready for us all as we age. During our time together, I will discuss numbers and data. I will talk to you a little bit about area agencies on aging and the Aging Network. And we'll talk a little bit about the integration of health care and human services. So anyone in here remember this graph? Perhaps you saw, but the U.S. population, perhaps you saw it in a sociology class. Age is on the axis in 5-year increments. Percent of the total population on the horizontal axis. Males are on the left and females are on the right. It was not long ago we were talking about this population pyramid in this graph and aging quite regularly. The history of aging for mankind, of course, lots of young folks and not too many old folks. Life expectancy in 1900 was about 40, And of course, we know today, 100 years later, it's almost twice that. Now let's skip ahead a little. 1970. The projection at that time was the pig and the python. Does anybody remember that mantra? They were referring to the baby boomers, right? People born between 1946 and 1964, exactly. Anybody in that range? Yeah. They said they would be an anomaly and they would pass through history similar to a pig passing through a python. Needless to say, let's skip ahead to almost to today. The reality, no pig. No pig, no python. The generation's flattened out and it's almost cylindrical. Let's give it ahead a few years, and it may even become top-heavy. That bar at the top is the entire 75 plus. So this is for the country, of course. So just look at that for a moment and think about the implications. What are the implications of that type of a graph and a population? What are the implications on our society? What are the implications for policies, for our legislators, for regulations, for public funding, transportation, healthcare? What is this going to do? What does this mean for us all, right? You can't have that kind of shift and not have an impact. According to Ken Dykewald, a research expert and leader with baby boom demographics, 2/3 of all of those in history who have lived to be 65 are alive right now. That is a staggering to think about that. That is huge. Now let's have a look at some North Carolina numbers. We have some, I'm not always sold on some of the projections. I think as you may have gathered from the first few slides, I like to, they're not always right projections based on what we know in the past. However, so what I like to do is we'll look at 1990, and we've got 2000 and 2010. This is North Carolina. You can see the graphs. The total population in North Carolina in 1990 was just over 6 million. And you can see the green, which is 60 plus, and how it grows over time. You can see and proportionately, the adults, age 20 to 59, are pretty much stagnant. And I mention that as well because when we talk about caregivers, those informal and unpaid individuals that support older adults, that population is not growing. Let's go look a little closer at North Carolina. So 2 years ago, 76 of 100 counties had more folks over age 60 than those under age 18. That's right here at home. So this trend is global, it's national, it's happening right here at North Carolina, of course. And again, if I ask you, think about the implications. What does this type of trend mean for our society? What does it mean for public dollars, for policies, for legislation, for business, for human services, for healthcare, the whole 9 yards? It's changing, right? It is changing. It's changing now, and it has been, and I think it will continue to. All right, let's talk about the Area Agency on Aging. Commonly referred to as AAAs, not to be confused with changing tires or call me for roadside assistance. I'd love to help you, but I don't think I will. We play a key role in planning and developing and the leadership of aging services at the local level. We also do a tremendous amount of education and training, just like this, being invited out to share our expertise on trends and what's going on today in aging services and the works. So to be sure that we're using the same terminology, is there anybody here not in healthcare? on a regular basis? Is there anybody? Two people, nice. Okay, so I want to make sure that we're using the same terminology. I have found out the hard way. We might say the same thing, but we mean different stuff. So according to the Older Americans Act of 1965, a senior is anyone over age 60. 60 or better, okay? And that's my frame of reference. So if I say senior, I mean 60 or better unless I otherwise specify. And a caregiver, when I talk about a caregiver, it is somebody providing informal and unpaid assistance to an individual over age 60. We know the stereotypical caregiver is a daughter with kids at home and with an aging mother. That trend is changing as well. There's more men getting into caregiving, and there's not as many caregivers around. Long-distance caregiving is playing a bigger role as well with our mobile society, trying to care for aging parents in another state, in another country, where have you. According to Rosalind Carter, there are only 4 kinds of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. I can personally say I have been in all 4 of those categories. Again, this is personal to me. I do it for a profession, but there's reasons, right? And I chose this profession, and I love aging, and I love what we're doing. All right. The federal focal point for aging services in this country is the Administration for Community Living. It falls under the Department of Health and Human Services, and they administer Older Americans Act funding. That's how we provide services at no cost to seniors, right? It's not means tested. It's not based on income. It's if you're 60 or better, you're eligible. But of course, the downside is we have a finite amount of money. We can only provide so many services, and then we have to put people on wait lists. In North Carolina, the Aging Network, and that refers to anybody receiving funds formally through the Older Americans Act, consists of 1 state unit on aging, 16 area agencies on aging, and that's the map you're looking at. And of course, we're right here in the center. They're alphabetical from west to east. We're Region G. That doesn't mean anything to you, and it shouldn't. It's just simply a way of keeping track of them for internal purposes. There are about 300 funded partners across North Carolina that we have formal contracts with to deliver services. Here in Forsyth County, we have a number of partners, including the county, the Department of Social Services, Senior Services, Senior Financial Services, the city of Winston-Salem, Shepherd Centers in Kernersville, Shepherd Center in Winston-Salem. We administer funds, they do direct services, and we help them do that and provide technical assistance. And of course, we have countless formal and informal collaborations and partnerships across the state. This is a big job, and we can't do it alone. This is our region here in North Carolina. By a show of hands, how many folks work somewhere in these 12 counties? Not everybody? No. But as the map previously showed, there is an area agency on aging in every county, or that covers every county. So if you have questions or you want to find out about the aging network in your community, please look them up. You can find them on the web, and it's quite easy. So this is us in the 12 counties. And just so, again, about terminology. When I mention home and community-based services, can you give me an example of a home and community-based service? Anybody? Hospice? It's certainly home and community-based, a little on the clinical side. PACE, the Program of All-Inclusive Care of the Elderly, yes. Again, very clinical, medical models, both of those. CAP, Community Alternatives Program, Medicaid waiver. Again, yes, very clinical, medical model. Meals on Wheels. Thank you. That's exactly. Now, these were right, but again, just very medical and clinical. Meals on Wheels. Give me another one. Senior Services delivers home and community-based services. What do they deliver? Give me an example of one of the programs or services that they have. William Tabb's Adult Day Services is an adult day care. Sure, if they have adult day health. Yes, a community-based service. You go there during the day, you get structured programming, services, meals, what have you, and then you go home at night. Give me another example. In-home services, absolutely. CNAs providing chore maintenance, meal preparation, things of that nature. What's a big one? I'm not hearing it yet. Oh, thank you. I don't see who did it, but thank you. Transportation. How do people get to your office? How do they get to the health care? How do they get to their primary care physician? How do they get to their follow-ups? Transportation. That's exactly right. It took me, I'm almost embarrassed to say how long it took me when I started the foray into healthcare. And I was talking to healthcare professionals, and we were both talking home and community-based services, and we're both going, I just couldn't put it together for the lot. It just never seemed to jive. Ultimately, I realized many healthcare professionals, when talking about home and community-based services, are referring to PT, OT, ST, that are all delivered in the home, but they're all medical, they're all clinical. Us in human services, when talking about home and community-based services, are talking about transportation, Meals on Wheels, adult daycare, senior centers, congregate nutrition, in-home services, volunteers, that type of day programs and services that are delivered in the community and to the home. So we were going like this. So I want to make sure now when I talk about home and community-based services, I primarily refer to human services. And I know many in this, and I have a slide that talks about social services. I personally don't like to use that as an umbrella term. I think there's generally a stigma associated with social services because most people, at least on the human service side, think of Department of Social Services. They think of means-tested, low-income programs, and there's a stigma. So I like to and prefer to call it human services, right? And we can talk about that. Just simply it raises and elevates, so much is based in our terminology and the way we talk about things, so I prefer that. All right. I was prefacing that because here are some of course, the services delivered by the Aging Network. And we just mentioned a few of them. The home-delivered meals. Meals on Wheels it's like saying Kleenex and tissue. Meals on Wheels is a brand name, whereas home-delivered meals is the service. Okay? So just to get that distinction between us. Adult day care, day health, in-home services, caregiver support, as I mentioned. Caregiver, of course, is the backbone of long-term care services. So much of it is provided informally through loved ones, friends, neighbors, and keeping people in home and independent. And so much is just thinking you're taking out somebody's garbage can, you're running somebody's errand, you're picking up their newspaper. All those little things that are done, but it adds up, and it allows people to remain independent. So transportation, as we mentioned, housing and home improvement, legal services, these are all services that we administer funding that supports here in the Piedmont Triad, and of course you'd find these across the state as well. Anyone, as I said, over age 60 is eligible for these programs. They are not mean tested. They are prioritized for individuals who need the greatest help, perhaps don't have caregivers, are self-declared as low income, what have you. But the average age of a recipient of home and community-based services in North Carolina is 80. Eligibility 60, average age 80. So we are addressing, of course, those with the greatest need. Sadly, our wait lists continue to grow. They're currently standing at about 10,000 for the state of North Carolina. So those are people who have formally contacted an organization and said, yes, I'm willing to be put on the wait list. And it varies across the state where the wait lists are, how long they are, and et cetera. So don't be deterred with making referrals, because there's certainly, once you get into the loop of services, there are other opportunities as well. It depends what county. Yes, there are wait lists for Meals on Wheels, or wait lists for what have you, transportation, community services. There are not necessarily wait lists for support groups, and it varies. It varies in the some of the wait lists might be simply not because of money, but because of volunteers. You can only deliver so many home-delivered meals. You need volunteers, right? Backbone. So if you don't have enough volunteers, you don't have a route in that part of the county, and somebody's calling, it's not because there's the money or the funds are not available. It's simply there's no route in that rural area. A few of the other services that we provide are long-term care ombudsman, which ombudsman is a Swedish word for citizen advocate. So there are ombudsmen in different areas, but ours, of course, are long-term care, and they support individuals in nursing homes, or SNFs, as they're commonly called in the healthcare arena, at skilled nursing facility or a nursing home. There are 90,000 long-term care beds in North Carolina. We have about 17,000 here in the Piedmont. So it's a large responsibility to keep all those people happy and make sure that their rights are being adhered to. Just to bring it back home to North Carolina, right now there are over 2 million people over age 60. Over 2 million. Of which about 1 million are over age 70 and 800,000 are rural. And of course, I'm sure you all are aware, we have about 1.8 million people on Medicaid. And of course, North Carolina did not do expansion, or that could be larger. So it's a large part of our population, of course. Talk about outcomes. It is proven that home and community-based services are beneficial to seniors by improving the quality of life. And of course, we're linked to improved health outcomes for high-need individuals, frail, elderly, older adults, etc. And we save healthcare dollars by decreasing other publicly funded programs and assisting seniors remain independent and at home safely. And I add that safely as a qualifier. Of course, at some point, somebody remaining at home could become a safety issue, and of course, we don't want safety issues. We want people to be safe and happy. I have yet to have anybody come up to me, though, and say, I can't wait to get in that nursing home. I just can't wait. I personally can't wait to get in that CCRC, a continuing care retirement community. I've seen some of those with golf courses, pastry chefs. Sounds good to me. I don't know if I can afford it, but I'm working toward it. And of course, I'm sure many of you in this room have heard that phrase, aging in place, perhaps. I prefer aging with choice. Not all seniors want to age in place. They want to be close to their family. Perhaps their family has moved, and they no longer want to be in the home where they're at, but they want to remain independent, but they want to be closer to their daughter, their grandchildren, their son, what have you. So it's not necessarily aging in place, but aging with choice. I want the decision-making process. I want to be involved in that, right? There was an example study done out of Brown University, and you can see research shows about home-delivered meals, how it reduces isolation, reduces loneliness, increases feelings of safety, and reduces falls and unnecessary hospitalizations. And of course, somebody mentioned CAP earlier, the Community Alternatives Program. It's the Medicaid waiver. And of course, it has been proven now, somebody to be on CAP, they have to be nursing home eligible, right? They're deemed eligible for nursing home care. But instead, with the Medicaid waiver, with CAP, they can remain at home. So and of course, CAP services are delivered at about 2/3 of the cost of keeping somebody in a nursing home. So institutional care versus community-based services. Not only are they cheaper and more cost-effective, they tend to be where people want to be. And they give people that choice. They allow them to decide, have some autonomy and some independence to where they want to live. AAAs are worried about your patients and seniors and their caregivers. The need has outpaced the resources, and from those data and the statistics I shared with you earlier about the country and North Carolina, we just simply can't keep up. The need increases, the cost increases, and the resources are decreasing. So it's an uphill battle. Here's a visual. Of course, the yellow line is the population, and the red line is the Older Americans Act funding. You can see the widening gap. Do you know every day in this country there are 10,000 people turning 65? Every day. So, I think I can safely say, because this is in reference to the boomers who started turning 65 in 2011. I can safely say almost 10,000 people every day are turning 66. Almost 10,000 people every day are turning 67. And so on, right up through to 72. This is simply, we just can't keep up with the need, and we got to work together to help make it happen. Meanwhile, in healthcare, the U.S. health system faces major challenges. Healthcare costs remain high at $3.2 trillion spent annually, of which an estimated 30% is related to waste, inefficiencies, and excessive prices. Waste being overtreatment, failure to coordinate care, failure in care delivery, fraud and abuse, and excessive administration. This is from an article from the National Academy of Medicine in the JAMA of 2017. I have seen a few other presentations recently with this same chart, but they did it a lot better than this one. It's kind of hard to read. See where that red arrow is pointing to the United States. The yellow is total healthcare service expenditures, and the blue is total service expenditures. Each one of those lines are a different country, and the U.S. spends, as you can see, a tremendous amount more on healthcare, a lot less on social services, and our healthcare outcomes are some of the worst in the world. So what's the disconnect? Social determinants of health, right? Everybody heard that term, social determinant? Yes, good. I have yet to see one definition that encompasses it all, but social determinants of health incorporate three broad areas, which are social, behavioral, and environmental. And depends on who you read, but up to 80% of an individual's health is based on social determinants of health. So that other 20% is their doctor, is their surgery, and what have you. 80% is based on where you live. Do you have a job? Do you have housing, entertainment, safety? Do you have transportation? Do you eat? All of those other things. It's finally coming true. So all of those things that social workers do and work on each and every day, and matching somebody up with the needs that they have in the community, that is helping somebody's health care. Opportunities for payment reform. Not long ago, I heard somebody in healthcare say healthcare is in crisis as they try to keep up with the changes based on legislation. Of course, the Affordable Care Act, Obamacare in 2010 started the ball rolling, but there are some other pieces of standalone legislation that have keep it going, and one of which is MACRA. It's Medicare Access Chip Reauthorization Act. And it has changed payment reform. It's going from quantity to quality. It's going to happen regardless of the revise and replace or whatever for Obamacare everybody's talked about. It doesn't matter anymore because there's this other standalone legislation that's going to continue to inspire changes in healthcare. So what is happening now is going to continue to happen incrementally over time to keep up with the changes as based in that act. As you can see, I mentioned 30% of the $3.2 trillion we talked about as waste is $960 billion. The Older Americans Act is about $2 billion a year. It is 0.2% of what healthcare wastes. Rounded, That's zero. Think about that for a second. But of course, I think what it does is it shows how cost-effective the aging network is, because we serve thousands and thousands of people and keep people independent, living at home with providing them choices. So there's a lot of opportunities. These past few slides that I have been referring to in the information comes from an article out of the Bipartisan Policy Center, which you might recognize Tom Daschle and Bill Frist, Republican and Democrat, high-ranking folks from the U.S. Congress. And now they're running this Bipartisan Policy Center, making suggestions on how to do health care. I've got opportunities in caring for high-need, high-cost Medicare patients. We must be thinking about ways to address the needs in the growing senior population. Decreasing caregiver support with the impending transition in North Carolina from fee-for-service Medicaid to managed care, which includes long-term service and supports. It's going to bring some big changes in North Carolina, right? And from what I've heard before of examples of a complex healthcare patient, they talk about somebody perhaps LGBT with dementia, low income, no transportation, and multiple medications. And healthcare this is complex, and we're trying to deal with it. Human service people, we do this all day long, every day. It's not complex, it's what we do. We got to work together to help folks and make that transition and keep them successfully making their own independent decisions as to where to live in a safe environment. Thinking at home, of course, an in-home assessment is a must. You can't tell what somebody's doing when they come into your office. If I come into your office, do you have any idea what my background is, what I need, what my home situation is? Just simply can't. And if I don't tell you, you're never going to know. There's a lot of proud people out there don't want you to know. But when you go into that home and you can see stuff, and you know then that they've got 10 stairs to climb just to get into their home, they don't have a working washer and dryer. One quick example in Cone Health, they had a patient come into their ED 130 times in 1 year. That's approximately $400,000 in cost. And this person, they finally went to her home. She was diabetic, and they found out she did not have a working fridge or electric. So what did Cone do? They bought her a fridge and turned on her electric. Guess what? She didn't come back. 130 times in a year. This is a true story, folks. All it took was one home visit to figure it out. Think of the money they saved. And not just helping about quality of life, right? But we know healthcare for much, it's about the bottom line. So you got to make both, right? Quality of life and a bottom line issue can be successful at both. It really can work together. I think it could be a win-win-win situation. We win because our AAA, we will serve more people successfully and help those who fall between the cracks. Healthcare wins. They save money and, of course, maintain their margins. And seniors win. Quality of life, remain at home, and have choices. Together, we can help save North Carolina Medicaid dollars and help improve the lives of North Carolinians. That's my contact information. I don't know if I have time for any questions. All right, folks, have a great day. Happy Friday.